Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
You must use an instrument to simulate the patient's jaw movements and to hold mandibular positions. We use an articulator. This instrument simulates the temporomandibular joints of the patient, and dental casts can be attached to it. Now, graphically, if we look at the skull, we can see the condyle and the lower, or in the mandible, and then the infratemporal fossa of the maxilla. Superimposed on the graphic illustration of the skull is a graphic illustration of an articulator. The lower member of the articulator representing the mandible of the patient, and the upper member of the articulator representing the maxilla of the patient. Now, we have also superimposed dental casts. These are positive reproductions of the patient's mouth, and these are mounted to the mechanical device which is simulating the movements of the patient. Now, many times, or many types of articulators are used in dentistry, from the very simple type of articulator to an average type of instrument to a more complex type of an instrument. Now, the differences being, besides cost, the fact that this very simple hinge-like articulator is not capable of reproducing the movements of the mandible to any degree of accuracy. There's only slight movements about the hinges in the posterior, little springs rather. Now, as you go to the average type of instrument, we have average dimensions of a patient built into this articulator. These average dimensions will give us, when we move the articulator, a more accurate reproduction or simulation of the patient's movements. Going further to the more complex instrument, it takes from the patient a more complex type of recording to set the articulator. This articulator is then further more accurate in duplicating the patient's movements. We're going to use the skull to review some basic anatomy and some basic mandibular movements. We see, first of all, the mandible, and we see that the condyle with the disc, the blue disc, fits into the infratemporal fossa. Now, with the skull in this position, we're going to duplicate the hinge movement of the skull. It is rotating about a transverse axis. This is the hinge closure. Now, we can also use this view to look at the protrusive movement of the mandible. If we allow the jaw to come forward, we see that the condyle and disc come forward, and it is guided by the posterior slope of the anterior slope of the eminence. Now, this movement is a translatory movement. In other words, the condyles are coming forward in a bodily fashion, as opposed to, they come forward in a bodily fashion as opposed to a hinge type of movement. There may be, in protrusive and opening movements, a combination of hinge and translatory movements. Now, changing the position and looking at it from the anterior, we will simulate lateral movements of the mandible. Now, the lateral movements of the mandible, as you have previously learned, the condyle to which to the side which the mandible is moving, which in this case would be this skull's right side, stays in a relatively still fashion. Now, as we move, it will come outward just slightly, and that slight outward movement of that condyle is called a Bennett's movement. And the side to which the mandible is moving is called the working side, or that would simulate a chewing side. So this is the working side, the right side. When the teeth are in the working relationship, it is the buccal cusp of the lowers in line with the buccal cusp of the uppers. The opposite side, the left side, would then be termed the balancing side. Now, the condyle on that side is coming down and forward and to the medial aspect. Now, we're going to have to get the skull in a little different position so that we can look at that balancing condyle. You can see the balancing condyle coming forward. The balancing condyle is coming forward as well as moving medially. Now, we'd like to show some of the parts of this Hanau articulator. The Hanau 2 model articulator is an average type instrument and is capable of only a portion of the movements that the patient can make. It will not be accurate to the nth degree. It is only an average replication of the patient's movements, for some of the reasons I'll show you a little later. Now, the upper part of this articulator that I'm arcing up and down, this is called the upper member of the articulator. It is composed of the upper member proper and a posterior, or looking at it from the posterior, a horizontal axis, or horizontal or transverse axis. The opening and closing movements of the articulator are centered around this transverse axis. The incisal pin is also attached to the upper member of the articulator, and its purpose is to prevent a closing of the articulator if the stone casts, for example, start to abrade on the occlusal surfaces. The incisal pin helps to maintain the vertical dimension of the articulator. Without it in and without the cast in, the upper member of the articulator would collapse to the lower member. Now, looking at the lower member of the articulator, we see it has a condylar element it has a vertical axis and a lower member proper with an incisal guide table. For now, we're going to concern ourselves with the condylar element and the basic movements of the articulator. We've already illustrated one, the opening and closing movement about a transverse or horizontal hinge axis. If we look closely at the condylar element, we will see that the condylar axis is moving through a center ball. The ball is representative of the skull's condyle. Now, if we open and close, the transverse axis is rotating through the center of the condylar ball. Now, we want to look at the track which the ball is held in. This is the horizontal condylar guidance, and this can be adjusted to what the patient's records may give you. If the patient has a steep condylar guidance, we set it such, and it could be very shallow or near zero. Now, this becomes important in the second movement that the articulator is capable of making, and that is a protrusive movement. Looking at it from the whole articulator, we see that if we bring the teeth into a protrusive relationship, that is, we've brought the anterior teeth into the protrusive relationship, we could see the condylar element has gone in a posterior fashion. If you remember the skull, which we'll go back to and show a comparable movement on the skull a little later, we remember that the condyle of the mandible came forward during the protrusive movement, whereas the condyle is going backward. And I'd like to show a couple of differences of the articulator from the basic anatomy at this point. First of all, the upper member of the articulator, I pointed out, has the condyle. If we looked at a skull, we would see that the mandible had the condyle. Now, in the protrusive movement, we go from an anterior position of the condylar ball to a posterior position in the protrusive movement. On the skull, we will see that it will be the opposite direction. This articulator is called a non-archon instrument, or a non-archon articulator, because the condylar element is housed in the upper member of the articulator, and if we move it in a protrusive fashion, the upper member of the articulator moves to the posterior. It is the opposite of what we will see happens on the skull, or what we have seen happen on the skull. Now, looking at the third movement, basic movement of the articulator, we're going to look at the lateral movement. Now, if I want to simulate the cast in a right working excursion, I have to move the upper member of the articulator to the left. And we could see that the working condyle as we illustrated on the skull sat in a relatively the same position, seated in the fossa, and rotated only slightly about a vertical axis. I'm going to move this articulator in the right working fashion, and we can see that that articulator, or that ball, moves very slightly, and it's rotating about a vertical axis. If we then look at the balancing side and that is the opposite side of the right working, we're going to have the left side is going to be in a balancing position. We see that the condylar ball goes toward the posterior, which in essence is in the patient an anterior movement of the condyle. Remember the downward and inward movement of the patient balancing condyle. This is simulating that downward and inward movement of the patient. Now we notice that the vertical axis of the articulator can be rotated. And that setting will more characterize what a patient will give you. Some patients may have a very little downward and inward movement of a condyle, while others may have a greater inward movement to the condyle. This setting about the vertical axis of the articulator will give you Bennett's angle, which you should be familiar with from the lecture on mandibular movements. Now we want to show sort of on an oblique angle that this vertical axis is set medially. You can see that it is set to the inner aspect to simulate that downward and inward movement on the skull. So let's go back to the hinge movement and show with a split screen the movements of the skull, the corresponding movements of the skull. Now, first of all, the opening and closing movements. We see that the horizontal axis of the articulator is running through the condylar ball and is just rotating within that ball. On the skull, what should be happening is the condyle in a live specimen would be rotating about in the lower compartment of the mandibular fossa against the disc. Now, if we also show on a split screen movement the protrusive movement, if we're going to simulate the protrusive movement, we have the mandible coming forward, the condyles coming forward in the translating forward, coming forward bodily. But on the articulator, the starting point is to the anterior, and I move the upper member of the articulator posteriorly to simulate a protrusive movement. If we look at the skull carefully, we see that the condyle is coming down and forward. So it's the opposite. The articulator, in this particular case, this particular articulator is moving in the opposite direction of the skull. Now I'm simulating the right working movement and the right condylar movement with the articulator and the skull. We see that there is only very slight rotation of the working condyle. On the skull, on a true patient, we would be seeing possibly a slightly more outward bodily movement of the working condyle. In other words, as we come to the right side, the condyle would also, as it was rotating about a vertical axis, this right working condyle would also come slightly lateral. And as it came lateral, could go upward, downward, or one of any directions. Now the articulator, to some degree, compensates for this immediate Bennett shift that we saw can occur in a patient. Now, if we look from the posterior at the articulator, we'll see that the vertical axes are divergent. This means that immediately when the condylar ball leaves the fossa, it's in an area that's a little bit wider in the condylar tracts. This allows a little bit of play in the articulator. We can see this. Now, if we were to have a purely vertical movement of the articulator in the working fashion, in other words, if there were no Bennett's shift, I would hold the articulator toward the working side, and there would be only rotation about the vertical axis. And if we looked at this the articulator's right condylar area, we would see that the brass sleeve on the horizontal axis is tight against the condylar element or condylar ball. Now, if I want to incorporate some of the immediate shift of the mandible, put in an immediate shift, an artificially introduced immediate shift of the articulator, I would hold the upper member of the articulator toward the balancing side. Now when I go into a right working direction, you can see the gap between the sleeve and the condylar ball. Now as we're rotating, this would also simulate the condylar, or the right condyle, the right working condyle, going slightly lateral. Now this will make up for the immediate Bennett side shift on the patient. Looking closely at the balancing movement and comparing the articulator to the skull, now we're going to simulate the right working movement, but we are now showing the left side, which is the balancing side. Now, we will see that on the skull, the condyle comes down and inward, down and medialward in this balancing movement. If we look at the articulator, it is going posteriorly as well as laterally to simulate the same movement. The articulator, we're moving the upper portion of the articulator, and obviously with the skull, the mandible is doing the moving. One variation we must consider when looking at anatomic counterparts from the skull to the articulator is the curved surfaces that the skull has. If we look closely at the fossa on the skull, we will see a curved surface of the anterior wall of the fossa. This is the surface which the disc and condyle articulate with. And then we consider the condyle which fits into that fossa. And if we look at the condyle itself and see and check its asymmetry, we see that it is not like a condylar ball or sphere on the condyle, but an irregularly shaped head. We must consider that there is a disc which is covering the condyle, though, and if we look at the articulator, we would see the straight line which is the path of the condyle in the various excursions, the protrusive and balancing excursions, and the spherical shapeness of the ball. Now this difference in the anatomic counterparts will also cause some error, and it enforces what we say, that the articulator simulates mandibular movements, does not duplicate them.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.